Well, we've been using the Coblation wand system for a variety of procedures. We use it for the soft palate for snoring, as well as for the inferior turbinates for nasal airway obstruction. I've been very pleased with the success rate of soft palate treatments for snoring, and it continues to be a minimally invasive technology with a minimal complication rate and high patient satisfaction. And the way I do the procedure is spray their throat down with 20% benzocaine, and after about 20 seconds inject with a 27 gauge needle, 1¼ inch, 1% lidocaine with 100,000 epinephrine in 3 locations or multiple locations so that the whole upper soft palate is infiltrated. I don't go laterally low because it tends to balloon the redundant mucosa. I just let it dissipate, and I use about 2.5 to 3 cc's of local anesthesia for that. Once I've done that, I let that lay there and dissipate for approximately 5 to 10 minutes to get the best anesthesia. The procedure itself I perform with the Reflex Ultra 55 wand, and that is performed through 3 different ports, and those ports I usually identify as median and lateral ports. And the lateral ports are approximately 1 centimeter lateral to the midline. The location that I enter the soft palate at is approximately 1.5 centimeters from the margin of the soft palate, because what I'm interested in doing is not affecting the soft palate musculature, but affecting the leading edge of the soft palate and the redundant mucosa of that leading edge, including the uvula, the tissue around the uvula. Entering the mucosa, I also try to go in at 90 degrees so that the area that the electrode touches the soft palate is minimized as it enters. I usually start on a power of 6. Advancing it all the way into the uvula runs the risk of there being problems with healing. And so what I do is I bring it down slightly lower than the margin of the soft palate. You'll often notice that on the first treatment the uvula is shortened, and in some patients dramatically so, and that depends on tip placement, proper tip placement. For the 2 lateral ports, what I do is position them 1 centimeter lateral to the midline and go in a vertical direction. So the probe first entering at 90 degrees and then rotating down in a vertical direction towards the margin of the soft palate. And in doing that, it creates scarring in a vertical position that is similar to putting a batten in a sail, such that it stiffens it along its axis. In people with very redundant mucosa, thin mucosa along the margin, I sometimes will sweep the wand tip along that margin to maximize energy disbursement along that margin. I always only do 10 seconds in each port to avoid injury to the soft palate. The Coblation system has a couple advantages, I think, over other radiofrequency types of treatment. It's more than simply a heat source. It has a multipolar electrode which actually reduces the volume of tissue underneath the mucosa. The advantage, obviously, over laser treatment is that it brings the tissues up to is much lower than carbon dioxide laser, and so postoperative discomfort for both those reasons is much reduced. And because it is a minimally invasive treatment, it can be repeated multiple times without reaching an anatomical endpoint for treatment. I've recently started using the Ultra system, and the Ultra wands go in very smoothly, also come out much smoother, I think, than the older style. So I'm actually very pleased with that technology and that improvement. Well, you know, there's 40 million people in the United States that have problems with snoring, and clearly many of them can benefit from this type of technology. Obviously, the 10% that do have obstructive sleep apnea need to be identified early in the selection process. The remaining 90%, for the most part, are very good candidates. It's best in patients with floppy tissues, thin, floppy soft palates, very elongated uvulas, and soft palates that are low in the pharynx, because this will tend to elevate and stiffen these tissues. The average number of treatments that I do for snoring is approximately 2. The reason why I do these procedures all in the clinic versus in the operating room is that I think in general patients and physicians would agree that it's much preferable to do something in an outpatient office setting than to do it in an operating room. One of the keys to that, I think, as I've learned, is to get them adequate anesthesia, that is, give them enough local anesthesia, although 3 cc's is enough for just about anyone. Proper placement of the anesthesia so that it's placed a little higher in the soft palate than you would you do the coblation itself, and let it have adequate time to disperse. And I think that waiting at least 5 minutes for disbursement throughout the soft palate, especially laterally, it really helps completely block the soft palate so that you don't have any problems with a patient having discomfort during the procedure. The patients are very happy with the procedure. It's, again, a minimally invasive procedure that offers significant reduction in snoring, and I usually shoot for around 80% success rate that is defined by patients no longer and their spouses no longer being disturbed by the patient's snoring.